this last thing I want to talk about, spend some time talking about, because this is probably the area in psychiatry where there's the most confusion, lack of clarity, and also lack of effective treatments, and this is in childhood onset bipolar disorder. And the question is this really the same as adult version bipolar? And the jury is out on this, okay? Some of the studies, they look at what's called narrow phenotype. Now, what this refers to is that they are using strict DSM-IV criteria for for diagnosing bipolar disorder. And there's lots of controversy that this may not be appropriate with pre-adolescent kids. If you're interested in this and read about it, you want to look specifically at what criteria they use, because these kids are pretty rare. What you get is a different version I'll show you here in a minute, which is referred to as a broad phenotype, okay, that is not based on strict DSM-IV criteria. So if you read the research, you've got to really carefully look at how did they make the diagnosis before you can derive any conclusions. And this problem's been seen before in medicine in general and psychiatry in particular, where they take somewhat related disorders and lump them together and then look at the outcomes. And that's not good enough, because it's a heterogeneous group of disorders that may have some symptomatic similarities. John Walkup, he's a really well-known child psychiatrist from Johns Hopkins. And he talks about this disorder, and he says it's only partially tongue-in-cheek. He said a lot of these kids that are being diagnosed with bipolar disorder don't have it. They've got a lot of emotional lability, but what they have is this: a mixture of ADHD, anxiety, depression, poor self-control, adverse life circumstances, a history of early fetal alcohol or drug exposure, substance abuse, lack of supervision, family dysfunction disorder. Okay? What do they have? They have all of the above. And his point, he makes a couple of points. One is he says, look, I'm a clinician and I consider myself to be a pretty good child psychiatrist, but boy, you bring these kids in here and it's like I have to struggle with one thing within myself, and that is feeling impotent. Because there are no single medications that really address this. You know, there's a multitude of problems. You do your best, they jump right back into these toxic environments. They've got, etiologies from multiple sources, that kind of stuff. He said, I think in psychiatry there has been a tendency to call a lot of these kids bipolar as a defense against feeling impotent. Oh, well, these kids have bipolar. And by the way, we have bipolar drugs. Let's give them bipolar drugs. Okay, that'd be fine and dandy if they worked. But they really don't work. And that might be okay if they worked a little bit, but were benign drugs. But they're not. They're heavy-duty drugs with bad news side effects. So really, the task here is to get all these kids that have really unstable emotional control and say they're not all alike. We need to go in here and try to carefully define subtypes and not try to talk about them as one group. And I'm really worried about just what really is a multitude of kids that are being given these bipolar drugs who may have something like this, and the drugs put a dent in it. Now here's the deal. You get a kid like this, you get another, let's say, another kid who has true bipolar disorder, and you get me getting ready to go in and be audited by the Internal Revenue, and you give us all Depakote for a week at rather high doses, and we're going to all be calmed down, if not asleep. Okay, does that mean we all have bipolar? No, it doesn't. And so a lot of times these kids get some behavioral control, but it's not really targeting the underlying disorder as much as it is, it's knocking them out. It's sedating them. It is medication-induced behavioral control. And again, if the drugs were safe, that might be okay, but it's not okay. All right. Now, you have drug-exposed babies. These kids show a lot of affect instability. Try to treat them with these drugs. Maybe 1 out of 10 is going to have some benefit, but a lot of them aren't. You have lots of kids that have persistent neurobiological problems with affect regulation due to early trauma, especially neglect. Those of you that have taken the biological basis class, we talked a lot about that. They're very emotionally unstable, but they don't have bipolar disorder, a lot of those kids. This is an attempt to carve out separate groups of kids that have been kind of put under this global umbrella, okay? So severe temper outbursts, grossly out of proportion in intensity and duration. Okay, they don't come out of the blue. They're in response to stressors, and most commonly the stressor is limit setting. Parents say, no, you can't do that. Okay, but they have these outbursts 3 or more times a week. Okay, onset after the age of 6 and before the age of 10. Now, if you look at extremely severe ADHD, it always starts before the age of 6. Okay, so they're trying to really exclude kids that have ADHD. They may have comorbid ADHD, but this disorder, in its pure form, has an onset after the age of 6, okay, before the age of 10. Also, the majority of kids that have true bipolar disorder, it occurs after the age of 10. There are cases that occur earlier, but most of the cases are age 10, 11, 12, somewhere in that ballpark. So again, I think this is trying to address that issue by putting this age limit on there. I can't remember if I told you this one or not, but this one of my patients, a couple of years ago, brought me a videotape, but I gave it back to her, so I wish I still had it. But it was from Oprah, and what was on there was this woman, this mother, had her son on Oprah, and this kid was diagnosed as rapid cycling bipolar disorder, and the child psychiatrist was on there, and the boy was 18 months old and being treated with Depakote. 18 months old, diagnosed with bipolar disorder. It's like, wow, now wait just a minute. Now, it's possible 10 years from now we come back and say, gosh, you know what? They were right. I wouldn't bet money on it. Okay, most of the experts say it's extraordinarily rare before the age of 6, and most of them it occurs about 10 or 11, pre-adolescent onset bipolar. Okay, mood, you have the temper outburst, but nearly every day a combination of irritability or some kind of anger and sadness. Okay, that's the dysphoric part of this. Okay, dysregulation with dysphoria. Continuous symptoms for at least 12 months. All right. Has to be present in at least 2 settings, not just at home, for instance, and never a period of time with abnormally elevated or expansive mood. This is clearly trying to get away from any hint of there being more classic manic symptoms. No history, and this as well, no history of decreased need for sleep, grandiosity, or pressured speech. Can coexist with ADHD and conduct disorder, okay, and substance abuse disorder. Of course, anything can coexist with that. So anyway, if this gets defined as a category, if this really truly represents a subclass of these kids that have unstable mood, that's good. Then they can start doing research on this to see what works. But the problem with this, is that these kids do not respond to mood stabilizers, the so-called mood stabilizers like Depakote and lithium.